Welcome back to my place for the sixth and final lesson on the knee. Last week we talked about osteoarthritis of the knee. We talked about DJD, or degenerative joint disease, is another name for osteoarthritis. There are different stages or levels. We talked about mild, moderate, and severe osteoarthritis. We watched a video of what that looked like. Risk factors for osteoarthritis. We talked about traumatic injuries, maybe in your youth or adolescence. Continuing on 10, 15, 20 years down the road leads to this osteoarthritis. Age and obesity. Some treatments we talked about: weight loss and exercise, physical therapy as a treatment, non-steroid anti-inflammatory drugs. We talked about some different types of injections, and surgical treatments. With surgical treatments, we talked about microfracture, autologous chondrocyte implantation, osteochondral autograft and allograft for OATS or OCA. I think we ended with the OATS or the OCA video. A couple pictures of what an osteochondral allograft looks like on the medial femoral condyle. And today we are going to end with end-stage osteoarthritis and the treatment. There's a point that the knee joint or the joint is too far gone. They're unable to do these biological replacements with cadaver parts, and it must be replaced with metal and plastic. So today we're going to watch a video of a complete or a total knee replacement, also called an arthroplasty. All right.
Knee that is painful as a result of osteoarthritis can severely affect your ability to lead a full, active life. The use of artificial knee replacement, also called knee arthroplasty, to treat osteoarthritis of the knee is becoming more and more common as the population of the world begins to age. Over the last 25 years, major advancements in knee replacement have greatly improved the outcome of this surgical procedure. Over the next few minutes, I will be describing the operation used to replace an arthritic knee joint. But first, let's look at the artificial knee itself. The artificial knee is referred to as a prosthesis. A prosthesis is a mechanical device that is designed to replace a biological part of the body. Each knee prosthesis
see that part of the prosthesis is metal and part of it is plastic.
The femoral component replaces the end of the thigh bone or femur. The femoral component is made of metal. The femoral component is shaped so that it matches the femoral condyles.
Medial and lateral condyles you can see.
The tibial component replaces the top surface of the tibia, or the lower leg bone. The tibial component most commonly consists of a metal tray that firmly holds a plastic bearing surface that will glide against or articulate against the metal femoral condyles of the femoral component. The plastic used is so tough and slick that you could ice skate on a sheet of it without much damage to the material. The patellar component replaces the back surface of the patella or kneecap. The patellar component is made of plastic as well. The patella glides in a groove on the front of the knee that is called the patellofemoral groove. The femoral component is shaped so that it also has this groove. The plastic patellar component glides against the metal of the femoral component inside this groove. The operation to replace an arthritic knee joint begins with an incision down the front of the knee.
The incision can be 6 to 8 inches.
The patella is dislocated and inverted so that the inside of the knee joint is visible to the surgeon, and there's enough room for the surgeon to work inside the knee. The soft tissues are held back out of the way using metal retractors. Once the knee joint is visible, the surgeon must remove the arthritic joint surfaces of the knee joint, including the femoral condyles, the tibial surface, and the patellar surface. The surgeon uses special cutting guides that are attached to the bone and guide a bone saw that removes the joint surface and shapes the bone so that the artificial joint component fits properly.
Patient is not awake during a total knee replacement.
Once each joint surface has been removed, each of the components is temporarily placed in position and the knee is assessed for stability and mobility. The surgeon will test the new knee to ensure that you have the best range of motion possible and the knee is not too loose or too tight. Achieving the right balance in these two areas is critical to both the function of your new knee and how long it will last. Once a surgeon is satisfied that the correct size of the components has been chosen and that the balance has been optimized, the permanent components are inserted into position. In some cases, a special cement is used to attach the metal components to the bone. This cement is placed between the bone and the metal as the component is pressed into place. Excess cement squeezes out the side and is removed. The cement hardens quickly, usually in less than 10 minutes. The incision is then closed using several layers of sutures. A bandage is applied to the incision, and you are returned to the recovery room. The hospital stay after the procedure varies between 1 to 4 days in the hospital. You'll be on your way home when you can demonstrate a safe
Recovery time for a total knee
to get in and
replacement
out of bed,
is about 3
walk up to
months
75
of
feet
rehabilitation. And we're going to continue on. We're going to watch a few videos. The Zach Miller video, you guys can watch that one on your own if you haven't seen it. Here's Joe Theismann, so this is an old one. A famous injury.
Going crazy. He's screaming both sidelines, get somebody out here, get somebody out here. And by the time the players wander out in the field and they see what's going on, it's just like, wow. Lawrence, the guy who made the hit, felt worse than probably Joe at the time.
LT actually did not say anything to me on the field, but I will tell you this. I remember everything that happened that night. I remember Bubba Tyer coming out and getting right here in my left ear. I remember telling Bubba, do me a favor, please, call my mom, tell her I'm okay.
There's Taylor over Carson, slamming, and you see the right knee, the right foot, and I knew that something was really bad when Lawrence Taylor leaped to his feet and beckoned over to...
All right, the next one that we're going to watch is Charlie Weiss. So this is a coach that's on the sideline. This one's kind of small. I don't know if we can make it larger or not.
The Notre Dame head coach right there. This is during a Notre Dame punt. Here's Weiss. John Ryan pushed into Weiss, and this is Joe Theismann-esque. Watch the leg on the coach.
Well, it's pretty small.
I mean,
It's hard to see. This one's a little bit better.
Back of his left knee, reportedly a torn ACL and MCL for Charlie Weiss, less than a week after his old quarterback.
Alex Smith, and you can look that one up on your own. Here's a gymnast that you may have seen in the past year.
An aerospace engineering major.
Such an impressive young lady.
Let's see how high she flies right here.
Yep. Ooh.
And I think she may be hurt. It looked like that ankle came down very awkwardly, and she...
It might have been more than an ankle there. Next thing we're going to do, we're going to review the knee. So go back to the Google form or your the knee injury lesson 4 through 6 here. Down on the 6th one, find knee review. Open the knee review, and I will be back to go through that with you. And we are back. We're going to go through the knee review. The knee review is on this side of my screen, and then we will go through and we will find the information in the presentation on the right. So make sure you have your last name, comma, first name, and what hour you are in. What are the 4 bones that make up the knee joint? Let's see on this slide here, the 4 bones that make up the knee joint are the femur, the tibia, the fibula, and the patella. So we have the femur, the tibia, the fibula, and the patella is the kneecap. The next question, the tibiofemoral joint consists of what 2 bones? Tibia, femoral. So it consists of the tibia and the femur. The patellofemoral joint consists of the patella and the femur. What type of bone is the patella? And I believe that's down a slide or 2. Talked about the patella is a sesamoid bone. A sesamoid bone. The next question is, how does the patella help us? The patella gives us a mechanical advantage working with the quadriceps and the quad tendon. It gives us a 33% higher or greater force with the patella as opposed to if we did not have the patella. Next question, a thin layer of connective tissue on the ends of the long bones. Thin layer of connective tissue on the ends of long bones. All right, here's articular cartilage, a thin layer of connective tissue on the ends of long bones. Next question, the shock absorbers in the knee are called what? It talks about the menisci are the wedge shape for greater stability, and the meniscus aid in shock absorption, distributing forces and improving stability. What are the four main ligaments of the knee that we talked about? Four main ligaments. We talked about the MCL, or the medial collateral ligament. We talked about the LCL, or the lateral collateral ligament. We talked about the ACL, anterior cruciate ligament, and the PCL, the posterior cruciate ligament. You can see how they cross in the center of the joint capsule in the knee there. What action does the hamstrings and the quadriceps provide? I believe muscles is our next slide that we can look at here. Quadriceps consist of the vastus medialis oblique, or the VMO, the vastus lateralis, vastus intermedius, and the vastus femoris. All aid in knee extension. Hamstrings all aid in knee flexion. We have the semitendinosus, the semimembranosus, and the bicep femoris. Are the muscles of the quads and hamstrings, and what action? O'Donoghue's triad. Scrolling on a little further. O'Donoghue's terrible triad is a torn MCL, a torn meniscus, and a torn ACL. MCL testing. MCL, or the medial collateral ligament. I believe MCL testing is our next slide. This would be a valgus stress test, where there's pressure put on the outside or the lateral side of the knee. Meniscus testing. We'll keep scrolling down further. We have meniscus tear. Test for meniscus. We have the Thessaly test, and that's where all of your weight is on one side, your knee is slightly bent, and then you rotate from side to side. And the McMurray test is a test in which the athletic trainer would do with you lying on the table. ACL testing. Continue through meniscus here. ACL testing. We have two types. We have slide testing. Go to ACL here. Testing. The slide test, we have the Lockman test, and the Lockman test is where you pull, where the athletic trainer or the orthopedic doctor is going to pull forward on the tibia to see if the tibia slides forward on the femur. The anterior drawer test is another one where they're going to pull the same thing. They're going to pull forward on the tibia. For ACL testing, anterior drawer test and Lockman test. What are some treatment options for the meniscus repair? For meniscus tears? There are several different treatment options. Let's see. Back to meniscus here. They can do a meniscectomy where they can take out part of the meniscus. Go back up here a little further. They can do a meniscus repair where they suture part of the meniscus back. Or they can do a meniscus transplant, which here's a picture of a meniscus transplant and how they put a cadaver meniscus into the knee joint. What is the percent of ACL tears that are non-contact injuries? So we're back to our ACL notes. The mechanism of injury is plant and turn often. And here we go, 70% of ACL injuries are non-contact injuries that involve sudden deceleration, such as cutting, pivoting, and landing on one leg. So 70% would be your answer here. Who is at risk for ACL tears? Anybody that's involved, who's at risk? Anybody that plays a sport where there's quick changes of direction, plant and turning. Female athletes are how many times more likely to tear their ACLs? Let's find our notes. Who's at risk? All right, females are 8 times more likely to tear their ACLs than men. Next question. Why might females be at an increased risk? There's some things here that we talked about. We talked about hormones as possibly a theory, or why that we are a more greater chance of tearing our ACLs. The wider hips, which increases the Q angle. Females have a decreased intercondylar notch width. The strength of the hamstring and the biomechanics, how they land. So that's something that we can work on and we can change. ACL treatment options, non-surgical versus surgical. The non-surgical is going to be physical therapy. And if you are not in an active profession and you don't plan to do any athletics, some people can get through with just physical therapy and strengthening the muscles around the quads, the hamstrings, the gastrocnemius, the soleus. Others are going to look into surgical options for ACL tear. I believe I have a slide. Treatment options, physical therapy. You can do ACL. There's several graft options. We have patellar tendon, hamstring tendon, quad tendon. They also use Achilles as one of the graft options. Can be allograft from a cadaver. Return to play for athletes undergoing an ACL reconstruction. In our notes, we talked about return to play, 6 to 9 months. It can also be up to a year for return to play. Is there anything that we can do to prevent ACL tears in athletes? And the return to play protocol, ACL tear prevention. A lot of our dynamic stretches, our dynamic warm-ups that we do in all of our sports at North are good programs, working on landing in the bent knee position, not with straight legs, so jumping and landing, agility, quad strengthening, hamstring strengthening. There's a lot of programs on the internet that are ACL prevention programs. It is hard to prove a lot of their, that they actually do prevent ACL tears, but there's getting to be better research on those. What is an osteotomy and how might it be used? Let's keep scrolling down. Patellofemoral problems, Q angle we talked about. Here's knee osteotomy. It can be on the tibia, the proximal tibia, or the distal femur are the two places. Osteotomy is just a cutting of bone. So what is an osteotomy and how might it be used? It might be used in the example of someone with a high Q angle to move the center of gravity more through the central part of the knee and out of the middle. So this person here in the picture is bow-legged, has Barrett's deformity, and a lot of the pressure is on the inside of the medial aspect of the knee. They want to shift that with an osteotomy, make it more normal so the weight goes through the middle, the central axis. A shattered patella is this type of fracture. Let's find our patella. Passed a little bit there. Patella dislocation. Here's patella. It's a comminuted fracture. Remember, if it's a bone is broken into 3 or more pieces, it's a comminuted fracture. Patellar tendonitis is also known as jumper's knee. Varus testing is done to test the LCL. So if we continue on, LCL and varus stress test to test the LCL, and that is where the tibia is pushed back in relationship to the femur. So that is true. PCL testing. PCL tear. PCL testing is posterior drawer test or the SAG test, the posterior drawer test where there's pressure so that the tibia is pushed back. If there's a lot of laxity, that could mean a torn PCL. And the SAG test, this was a video we watched, and then the tibia just kind of shifts back or sags back. So posterior drawer SAG test. When is Osgood-Schlatter's often developed and who is more likely to develop? Going to Osgood-Schlatter's in our notes. Here we go. Mostly affects males ages 12 to 16, can affect females ages 10 to 14. What joint does the IT band cross and where would there be pain? With IT band syndrome, we talked about pictures of the Osgood-Schlatter. IT band, we talked about how the IT band is a thick band of fibrous tissue or fascia that covers the hip joint. And then if I were to move my screen here, it also covers the outside of the knee. So hip and knee. Symptoms of osteoarthritis, continuing on. Osteoarthritis of the knee. We have, I think I missed the symptoms. There we go, symptoms. Here's a whole list of symptoms. Pain that increases with activity. The knee is stiff. There's an antalgic gait. Antalgic gait, remember, is where you're not walking well because of the pain, so it changes your gait pattern and how you walk. Chronic swelling, joint tenderness. Osteophytes grow on the joint line that kind of stick out to distribute the forces. Joint space narrowing and loss of range of motion. Crepitus, also the grinding sound or feeling. Risk factors for developing osteoarthritis. We started our lesson today. A traumatic injury, either in youth or just years previous to the development of osteoarthritis, is a big one. Age, it's degenerative joint disease, so over time it degenerates. Some people, it can degenerate very rapidly or very quickly, and other people, it takes years and years for this osteoarthritis to develop. Treatment options for osteoarthritis: Physical therapy would be the non-surgical treatment options. Surgical treatment options, we did talk about several of those. Also, weight loss and exercise are the non-steroid or non-surgical option. Taking medicine, injections like HA, PRP, cortisone, and then surgical options. We talked about microfractures where they're drilling little holes in the bone to try to create a scab that will cover that cartilage. Autologous chondrocyte implantation is where they take out cells and they grow kind of a graft and they put it back on the femur. Osteochondral allograft transfer is OCA, and then autograft transfer. An autograft, remember, is from your body, and allograft is from somebody else's or from a cadaver. We watched a video on OCA, or osteochondral allograft. And the last surgical option for end-stage osteoarthritis would be a knee replacement. All right, so that wraps up our knee unit. We will let you know what the plan is for next week, and we will see you soon.